Assalamu alaikum. Good afternoon to all of you. My name is Walid Tantawi from Ain Shams University. I'm so delighted to participate in this session on the topic of preterm labor. And I would like to introduce our guests, Professor Nanda from the UK, Professor Jacobson from Sweden, and from Ain Shams University, Professor Al-Ghitani, Professor Al-Bishri, and Professor Al-Mandour. One of the very hot subjects in obstetrics, preterm labor. Preterm labor is a global health problem, and according to the WHO, more than 13 million preterm babies were born in the year 2020. And preterm birth complications are the leading cause of death of children under the age of 5 years. And across countries, the incidence of preterm birth is in the range of 5 to 15%, and it's a major contributor for perinatal morbidity and mortality. And the best way to begin is really from the start. So I would like to start with Professor Nanda with the very first question. What are the most alarming symptoms of preterm labor, please?
So that's a very variable answer to that question, because if you have somebody who has regular contractions, regular painful contractions, which is leading prior to 37 plus 0 weeks gestation, because that will be your preterm gestation. And then of course, you've got less than 24 weeks, less than 28 weeks, less than 32 weeks. That's the various gestational ages of very early preterm labor, early preterm, those gestations. So you've got contractions leading to cervical dilatation, cervical effacement. Those are the signs of preterm labor. However, these need to be differentiated with the signs of Braxton Hicks, mild tightenings in women, but also things like other obstetric complications like abdominal pain, which is a symptom in pregnancy, or abruption, which can lead to preterm labor.
Thank you. Professor Jacobson, would you please tell the audience what are the most reliable signs to make the diagnosis of preterm labor?
It is the kind of contractions that are observed. And so the story, the history of the woman, and also together with our examination, it might be that we either kind of palpate the cervix and see that it is a progression of dilatation, or that we use vaginal ultrasound to examine. I think in certain situations it can also, especially very early, to do a regional gynecological examination to see first before you do any kind of examination, because sometimes in early pregnancy it can be very dilated and open. So I think that that is the most reliable signs that we can look at. But otherwise, I think if you only with signs means suggesting, I mean, it's contraction. It's certainly contraction. Or we have just recently published a paper there. We normally talked about two main types of spontaneous preterm delivery. It's either contraction or it's rupture of membranes. But we have also been able to show by doing amniocentesis that even if a kind of primary bleeding might be as much inflammation and infection in the uterus. So today we have actually three variants of preterm delivery: the bleeding, the contraction, and the rupture of membrane.
And would you depend on the external fetal monitor to evaluate uterine contractions, or you prefer clinical evaluation?
I think that if the woman is seeking care, it's the most important thing to do the examination to investigate what, and not really the symptoms. I mean, symptoms. It can be so many versions of this.
And And would you order certain lab tests or radiological tests to confirm the diagnosis?
The first thing is to do vaginal examination and then do maybe a vaginal ultrasound or palpation. I'm at that stage only to diagnose. We don't use anything more. That is what is needed in our setting. It can be very different, of course. Other tests can be needed if you have a patient who is very far from hospitals and things like that. So it needs also time. I think the investigation is also time. Do it multiple times if you aren't sure. But if you don't find any kind of progress, some dilatation or so, often you can send these women home.
The clinical evaluation is the most important in evaluating these patients.
Together, the clinical, the symptoms driving the women to the hospital, the investigations is helping you. Palpation and vaginal ultrasound is the thing. Yeah.
My next question is to Professor El-Ghitani. What is the role of ultrasound, both abdominal and vaginal, in the evaluation of these patients, please?
I would like to ask first, are we talking about prediction of preterm labor or the patient who is in established preterm labor? If we are talking about the prediction of preterm labor, then we need to look for the length of the cervix. As we all know that short cervix is associated with high incidence of preterm labor. The difference, when to start measuring for the length of the cervix. Personally, I do measure of the cervix if I have suggestive history, for example, history of preterm labor, extreme of age or something like that. I start from 16 weeks using vaginal ultrasound, and I have a cutoff point of 2.5 centimeters. Shorter than that, I should take an action. If we are talking about a patient who is already established in the preterm labor, then we have an abdominal ultrasound, first to exclude malformations, which is a very common cause of preterm delivery, assess the amount of liquor, and possibly assess the length of the cervix through the abdominal ultrasound. Vaginal ultrasound in the patient with established preterm labor in our country can be tricky because the patient will assume that vaginal ultrasound has contributed more to the possibility of preterm labor. Another point is to locate the placenta because it can have an effect on the management, subsequent management of the case.
So basically, if a patient presenting with symptoms suggestive of preterm labor, and after examination, if the cervix is less than 3 centimeters dilated, you would do a vaginal scan to check the length.
I would do an abdominal scan. If I have checked digitally and found the 3 centimeters dilated cervix, there is no point of vaginal. It will do abdominal for other reasons. Okay. For the check of the placenta, check of the malformation, the amount of liquor, and so on.
Right. Thank you. Professor El-Beshri, what is the role of amniotic fluid assessment in the diagnosis of subclinical infection, please?
I'm not sure about the question. Do you mean amniotic fluid assessment as an ultrasound or amniotic fluid assessment as a culture or as an infection?
I'm talking about amniocentesis for cultural sensitivity because as said and mentioned of many of the texts, subclinical infection might be the underlying cause.
I think it will take a lot of courage from someone to stick a needle into somebody who's got preterm labor, because first of all, if anything goes wrong, and she is anyway liable for a rupture of membrane, you know, if this preterm labor carries on, she will end up most probably delivering if we don't take an action. And part of her delivery might be a rupture of membrane. So if you stick a needle and she ends up with a rupture of membrane, then you're going to be accused. So I don't think I would go for that. Again, if you've got an infection and you're sticking a needle, you're already increasing the risk of infection anyway by doing amniocentesis. As ultrasound assessment, I can't see any role. You know, if you do an ultrasound to check the amniotic fluid index or anything like that, unless you are suspecting with the preterm labor, preterm rupture of membranes, which will be easily diagnosed with the speculum examination, actually. Again, looking at tests from the amniotic fluid, like fetal fibronectin, which is a very good test. Unfortunately, we don't have it in Egypt because it's pretty expensive. But it's one of the tests that's actually included in the, even with the ultrasound imaging, you put the length of the cervix and you add to it the fibronectin, and it gives you a risk assessment of preterm labor.
Professor Jacobson, you would like to comment on Professor El-Beshri's notes, please?
Yeah, it's always possible to discuss to do amnion or not. I mean, there are substantial number of hospitals in this situation to try to drive the science further in doing amniotic fluid sampling in here. I think when it comes to the term of preterm rupture of membrane, that is, then you don't have that kind of argument regarding this. So it's possible, and then the possibility is then to examine with cultivation, with PCR, specific PCR, but also with different kind of NGS techniques, so you get the bacteriology. And there are also new tests on this with a bedside nanopore that you can have a kind of idea about which bugs are involved. What you also can do with the with amniotic fluid is that you can test it for inflammatory marker. So to be able to discriminate between intraamniotic infection and intraamniotic inflammation, because inflammation in the uterus can also be caused by alarmins or by non-infectious reasons, so kind of sterile inflammation. It's also possible to do this. I mean, many centers like in the US, in Wayne State University in Detroit, they have done it for many years, and there are also some European centers, including Barcelona, who is doing this, and they're doing clinical trials, because one possibility and one of the big questions is that should we keep the baby inside in a hostile intrauterine environment? If we keep them inside, is it possible to treat them with certain antibiotics to really be able to mitigate the inflammation? And there it's proven that there are kind of combination by cephalosporin, by clarithromycin, and by metronidazole to really reduce the inflammation by doing repeated amniocentesis in this sense. But you need to do it very careful. I think it's very important to say that. It's also because of the setting, of course. You need to be able to take care of a baby that comes out with or without amniocentesis.
And just to add to the investigation portfolio, in terms of, NICE, National Institute of Clinical Excellence, recommends in terms of screening for women with risk of preterm labor, ensuring a midstream urine. So, because urinary tract infections, subclinical UTIs increase the risk of preterm labor. But then also when you have PPROM, which is preterm pre-labor rupture of membranes, using a vaginal swab for things like IGF-BP1, which is insulin growth factor BP1, that is a good and a reliable test with a cervical fluid to see whether somebody's ruptured the membranes or not ruptured the membranes.
Thank you. Professor El-Beshri would like to make a comment? Yeah.
No, I would like to ask Professor Jacobson, so is amniocentesis part of your workup for preterm labor? And if it is it done for everybody, or when does it come in as a role? And how do you counsel women if they end up, breaking their water after the procedure?
Yes, so we don't use it as a kind of clinical tool. Barcelona uses it as a clinical tool. And Professor Gatacos' department there in Barcelona, hospital clinic. We have used it, and we have done a clinical trial on it, and we have been able to better understand the inflammation, infection. We didn't have any complication on that side. There are some studies that are published in prenatal diagnosis from from another group that is also showing their risk of complications in this, but it's PPROM. It's not preterm labor. So I think that it should be reserved mainly for research purposes.
My next question is to Professor El-Mandou. Regarding the antenatal steroids, would you start steroids as early as how many weeks during pregnancy?
I think that there is general agreement in most institutes of the value of giving steroids between 24 and 34 weeks and up to 36 weeks if there is clinical judgment for this. But the problem here in Egypt is in neonatal care. If there is early preterm labor about 25 or 26 weeks, does giving steroids at that time add help? Yes, it will be best, but we have the addition of the help of the neonatal ICU care. The usual fluorinated steroids that pass the placenta, beta or dexa, in the usual regime, 24 milligram divided doses. And I think about the other question of the rescue dose. Yes, if 7 days have elapsed and the preterm labor didn't ensue, you could give another dose if you are still suspecting that preterm labor might occur. I am one of the persons, I think, at my residency 25 or 30 years earlier, we were used in our Ain Shams hospital to give weekly doses, and we've seen so much hypertension have occurred, gestational diabetes mellitus, and thus such attitude should be totally inhibited. I mean, the maximum dosage is twice. The first one and a rescue dose after 7 days. Yes.
Right. So after 7 days, if no labor has taken place, you advise a repeat course, but the maximum are 2 courses during pregnancy.
I beg to differ. I give only one course.
One course.
And a rescue course it does anything. Actually, the beneficial effect of the steroid extends more than 7 days. Actually, if it's taken late preterm delivery, for example, 31, 32 weeks, you need not to repeat it. This is number one. Number two, strong drugs tend to have strong side effects. So you have to be careful. If you are not sure that your patient is truly in risk of preterm delivery, I withhold the steroid. Because we have now in Egypt an era where everybody is going for elective cesarean section, is going to receive steroids irrespective of the duration of pregnancy. This is, I beg to differ with that attitude. You have to limit the use of steroids because it have a serious adulthood or childhood side effects.
So if a patient had a threatened preterm labor that was arrested and stopped, and she went home, but she came back a week later with symptoms of preterm labor, you, sir, you don't give a rescue or a repeat dose?
I think that we wrote a FIGO paper, a very simple FIGO paper on this. We don't recommend between 34 and 36 weeks at this stage because it's so much unclarity, and WHO is performing a study in India on this that would be very helpful when we get it. Otherwise, I pretty much concur with Professor here that to do the first wait a week and so it's something in between your position is that the lady is coming back in and is really going to deliver this time. Then you do the rescue dose, but not regular because she's still in hospital and have a short cervix. The rescue dose is only when there is really going to deliver and not multiple courses. I like your response very much in this. We really avoid on that. I just also want to say thank you for the invitation, and I need to leave now, so I leave you here. I'm so sorry.
Thank you very much.
I'm flying
Thank you
home,
for
so
being
thank you
with
for
us.
the invitation. Fantastic meeting. Good luck, Egypt.
You're welcome. Thank you. Thank you, sir.
Have a safe journey. So I just wanted to say the
Please.
primary point is going back to the first stage of diagnosis, the first steroid. So be very careful of when we will be giving, so whether it is clinical examination, cervical assessment, serial cervical assessment, full blood count, CRP, that dose is important because your rescue dose will depend on your index dose.
Regarding tocolysis, I would like to ask Professor El-Ghitani about the patient selection criteria. Which patients are candidates for tocolysis?
First of all, patients without a ruptured membranes. If you have ruptured membranes, I think it's better to leave the patient for the natural process. Patients without congenital malformations, of course, and patients without medical problems, patients without hypertension, without heart disease or something like that. We all know this basic. The point is when to start tocolysis and when not to start tocolysis.
The minimum age limit for tocolysis and the maximum, please.
I think I would start tocolysis as soon as, once the patient has developed the receptors for the tocolytic drug, which should be around between 24 to 28 weeks. This is the minimum. Before that, it doesn't work. The latest tocolysis has its side effects. So if you have a good neonatal care, I think after 4 weeks, we need not to give tocolysis. You just wait and hope for the pediatrician to support you in the outcome.
You would start from 24 weeks and up to 34.
Yes.
Thank you. Professor Nanda, would you please tell the audience about your practice? What is the first and second lines tocolysis that you would actually do in your practice?
Well, firstly, in our practice, we've got a very high threshold of giving tocolysis. The Royal College of Obs and Gynae and NICE recommends only 2 conditions where you should give tocolysis. Either you are buying time for antenatal steroids, whether it is 12 hours or 24 hours apart. And secondly, whether you are transferring to a unit, say for example, it's early preterm 24 weeks, transferring to a tertiary unit where you need to buy that time. So that's one thing. Second thing is the drugs that are used for tocolysis, I mean atosipan, which is oxytocin receptor antagonist, that is a licensed drug, but for the purpose of cost and for the purpose of ease, our first line is nifedipine. So we give oral nifedipine and you give 3 doses half an hour apart, and then you can continue it 8 hourly till 72 hours. The efficacy is similar to atosipan. Atosipan is more invasive, it is more expensive, and it's an intravenous drug. So the first line is nifedipine, and the second line, unless there's a contraindication to give nifedipine, and the second line is atosipan.
So it's always short-term tocolysis for 48 hours for steroids or transfer of the lady to another tertiary unit. And the first line is calcium channel blocker followed by oxytocin antagonists.
I mean, you have rarer situations. For example, somebody's had polyhydramnios, she's a short cervix, you've done an amnioreduction, then she has the uterine activity. Those are kind of fetal medicine situations where you would give tocolysis, but not with ruptured membranes. Otherwise, those are the 2 main indications.
Professor El-Bashri, do you have experience with the oxytocin receptor antagonists?
No, first of all, no, I honestly don't, because it's quite expensive, so it's not available here in Egypt. But I was going to ask Professor Nanda, what about magnesium sulfate? Magnesium sulfate is commonly used in Egypt. The reason why we use it, I know it's not within the guidelines that it's a tocolytic agent, but it actually works as a tocolytic, plus it's for brain protection if the babies are below 34 weeks. So is it part of your protocol? Because here in Egypt, it's considered, you can be actually criticized if you've not given magnesium sulfate to a preterm baby and ends up with intraventricular hemorrhage, for example. So what are your views about that?
Thank you very much. That's a good point. So we do, well, firstly, there's no role for oral magnesium sulfate in, yeah, exactly, because many countries still have empirical oral magnesium sulfate, so there's no role of that. In the UK, from 24 to 26 weeks gestation to 30 weeks gestation, we would give Maxulf for neuroprotection. So that is irrespective. If somebody has come in preterm labor, imminent preterm labor, we would give Maxulf. And that's the same practice as yours. Yeah, so we would give 4 grams bolus, and then minimum you need to have 1.5 hours of Maxulf in the circulation to have some neuroprotection benefit to the baby, but we would follow the eclampsia protocol and we would give.
So magnesium sulfate is a weak tocolytic, but it's very good
But
for neuroprotection.
would you combine this then with the nifedipine? Because there's a problem combining it, or do you not worry about that?
So this is extrapolated data from preeclampsia and severe preeclampsia. So magnesium is a weak tocolytic. It is a membrane stabilizer, and it is not really an antihypertensive drug. So the biggest problem that we have with nifedipine is the plummeting of blood pressure, headaches. So we don't see that. We would give, and these are women that would be continuously monitored. So we do not have any problem in mixing the two.
May I add one comment, please? There is a common belief in our young doctors that once your patient have started contraction, you give her progesterone, whatever the formulation you are going to give. It has no effect.
That was
Once
next
the
question.
patient develops preterm delivery, progesterone has no effect. It is useful only in prevention or prophylaxis against preterm. This is one point. Another point, we still have some drugs which are obsolete outside. For example, beta-sympathomimetics. There are no use for beta-sympathomimetics for preterm. It stopped about 15 years ago outside. Still, some of our colleagues use beta-sympathomimetics. It increases perinatal mortality. It doesn't decrease it. Please don't use progesterone as a treatment. Don't use beta-sympathomimetics.
So progesterone can be used for prevention of preterm labor in high-risk selected cases, but not for the treatment of acute attack of preterm labor. And beta-sympathomimetics shouldn't be prescribed. And what about the role of empirical antibiotics, Professor Al-Bishri?
Yeah, definitely I would use antibiotics. I mean, there's the Oracle trial many years ago proved that there is a significant difference if you give antibiotics compared to placebo, that it actually prolongs pregnancy.
Right. So regardless of the group B streptococcal status, you give empirical antibiotics.
Well,
What do you usually
it depends on where you're practicing and whether where you're practicing you actually do a group B strep screening or not, or whether you give antibiotics to everybody. So it depends where you're really practicing. Our problem is in Egypt. I don't think I've actually seen a report of a group B strep in any of the high vaginal swabs that we've taken. I'm not sure why, whether we are unable to culture it or whether it doesn't exist, to be honest. But I've never, and I'm not sure whether anyone has come across a group B strep report. So that's why we give antibiotics, you know, like a blanket thing, everybody.
Professor Nanda, you would like to make a comment?
Yeah, that again goes back to the point of diagnosis. Are we giving empirical antibiotics for threatened preterm labor, or whether we're giving antibiotics for preterm labor? So I completely concur with the Oracle. If somebody is imminently having preterm labor, then yes, you would treat them for, if you don't have GBS status, you would treat them for antibiotics, with antibiotics. But if somebody is just come with some contractions, you've done the cervical assessment, cervix is nice and long, you've given some painkillers, those are the women that we would not give empirical antibiotics to. Because the big problem that we have is, again, antibiotic resistance, and the gut effect on the gut of a preterm baby. Preterm babies with the commonest antibiotic, which is coamoxiclav, has got a higher risk of developing necrotizing enterocolitis. So we choose our antibiotics carefully. For women that are going into preterm labor and they are progressing in preterm labor, we would give them the GBS prophylaxis. The other place for antibiotics is the 10-day course of erythromycin that we would give for preterm rupture of membranes, preterm pre-labor rupture of membranes prior to 34 weeks.
Thank you very much. Professor El-Mandouha, do you have a place for emergency cerclage in your practice?
Actually speaking, I have never did it before. I've just heard it from some of my colleagues. But I think we must differentiate between what is the main pathogenesis of the preterm labor. Is it just mechanical or structural problem in the weakness of the cervix? And I also think is if we are in the week 20, 22, it is too advanced to perform such a procedure. For myself, I didn't do it. I'm afraid to do it. I'm afraid to have after it rupture of membrane. We could have other opinions.
Professor El-Bishri, I know you have done
Yeah.
few cases. I do remember a difficult scenario. You know, when the membrane's hourglass outside the cervical canal, which is mildly dilated above, that's a very, very disturbing scenario
Yeah.
and frustrating. Would you do emergency cerclage for such cases?
I would actually, definitely. But, I mean, first of all, I would counsel the patient that if we're not going to do anything, she's going to miscarry now. If we're going to do something, she might have a chance to carry on. What I tend to do, I don't rush into doing it. I give antibiotics, I give tocolysis, I put the patient head down, and I wait 48 hours. If everything is okay, then I would use a Foley's catheter, fill the balloon, push the membrane back, and put the cerclage. And again, I think it's 50-50. We've all had cases that carried on, you know, up to term, and we've all had cases that within a week she broke her water and you had to remove the cerclage. So I think it's worth attempting, and you know, a lot of time, you know, if you keep on doing it, you're going to get better at doing it, and you're going to get good results actually.
Would you give them antibiotics and progesterone after the cerclage placement?
I would, even though that's not the guidelines, and the guidelines are very clear that there is no role of progesterone prolonging pregnancy. But actually, you know, sometimes you've got to forget about the guidelines and follow your personal experience that those women actually carry on for quite few weeks until they reach a reasonable age where the SCABU is capable of looking after the babies. And
Hopefully.
it all depends obviously on the backup, you know, neonatal service that you've got where you're working.
Thank you. Professor El-Ghitani, after an attack of preterm labor on sending the patient home, do you give them advice regarding the exercise? Do you give advice regarding sexual activity or complete bed rest?
First of all, what is clear, definitely not a complete bed rest. Home rest possibly, but definitely not
It
complete
doesn't
bed.
help, doesn't help.
Actually, it might be more harmful than that, more bad things than good things. Physical activity, I allow physical activity short of exhaustion, whatever the kind of physical activity. Going to gym, I would advise against, for example. But if she is about to go back to work, if she has no exhaustion, I would allow her to do that. Sexual activity is a matter of query. Theoretically, we should avoid sexual activity in a patient who have rested after acute phase of preterm labor. But I don't think this advice is going to be followed by all the patients. Most probably they are going to break it down. But my advice would be no complete bed rest, physical activity short of physical exhaustion, and try to avoid sexual activity.
Is there any role for progesterone in these patients?
I don't think so. I don't use it.
Thank you. Now, if after the patient has gone home and she comes back with another episode of preterm labor, uh, Professor Nanda, would you repeat the course of glucolysis or max alpha or steroids? Would you repeat any of the three interventions?
The only thing I would repeat, if it is needed, is giving a rescue dose of steroid. If it is more than 7, ideally 10 days more than the last, and only if delivery is imminent, A, and secondly, when if the gestation is at a time where the baby would benefit from steroids. I wouldn't go do anything else.
You will give a rescue course of steroids under the circumstances or the indications as the first course, but you never repeat neuroprotection by max alpha or glucolysis.
So the repetition, there's not a lot of strong body of evidence about giving repeated Maxal. So those are individualized circumstances, and we would not repeat tocolysis.
Now, yeah, please.
I mean, it's when I think about it, you know, if you have a patient in the UK coming into preterm labor, she's about 24 weeks. Let's say take the minimum, you know, gestational age. So if you give her tocolysis and she goes home and she comes back at 26 or 27 weeks, I think from your point of view, that's an okay baby for the special care unit. But for us, it's extremely premature again. We need to push it further and further and further. So I think this might have an effect on, you know, your management.
I think this is why this discussion is interesting, because it goes back to what I was saying about why you would give tocolysis. In the UK, you would give tocolysis only for those two reasons, which is giving time for steroids and then doing an in utero transfer. So our idea is, if she's presenting in a peripheral hospital at 26 weeks, she's steroid mature, but she now needs, you know, she would ideally need to be transferred to a tertiary unit, either in utero or ex utero. But we would not give repeat tocolysis. But again, there's no hard and fast rule for these things. Preterm labor has got this beauty that a lot of these cases are individualized.
Actually, I have two special situations. One is not written here, and that's for my professor, Professor Al-Ghitani. The preterm breech, how would you deliver, or what is your protocol for delivery of the preterm breech, please?
A very tricky question. Yes. If I have a reasonable belief on that, there is have a fair chance of survival, for example, above 32 weeks, I would go for cesarean section. If it's less than that, I would counsel the patient, saying the chances are slim, and preterm cesarean section is going to affect your future reproductive career. And I think you might give her chance for vaginal delivery. But definitely about 32 weeks or more, if she is a breech, I would go for cesarean section.
Professor Al-Mandoor, do you have any special management plans for twins as regarding prevention of preterm labor?
Yes, I think that we must screen at her early second trimester for the cervical dimension. And I think we've abandoned the use of ordinary or the usual cerclage we have used to done a few years ago. I think just measuring the cervical length I am in this situation, I am with prophylactic progesterone. I know this may be not the usual practice, but I think this will be helpful.
For all twin pregnancies, you give progesterone for prophylaxis? Or selected cases only?
We are talking about more or less than 25 millimeters. It is scientifically speaking, surely, if you are less than 25 millimeter. But this is a tricky question.
So we have two comments from Professor Al-Ghitani and Professor Nanda, please.
I think meta-analysis, Cochrane library, the NICE guidelines. The records guidelines are clear-cut. Cerclage in a patient with multiple pregnancy without history of previous history of preterm is dangerous. It is harmful. It's going to shorten the duration of pregnancy. The idea that our colleagues in the IVF program and they have multiple pregnancies, they routinely do cerclage, this is totally wrong. It shortens the duration of pregnancy and doesn't prolong it. Please avoid this practice.
So, completely agree. I just want to quote some additions from the NICE guidance for preterm delivery for multiple pregnancy, and they have updated the preterm delivery section this year. So, I agree with doing cervical length, single cervical length between around 16 to 20 weeks. The cutoff is 25 millimeters. If 25 millimeters or less, NICE guidance is now recommending 200 milligrams of progesterone to be given daily at night till 34 weeks. Now, that can cause lots of discussion, but I'm just quoting the NICE guidance. We've written comments on that. The second thing is, I completely agree, doing empirical cerclage is harmful in multiple pregnancies rather than beneficial. But the only place in multiple pregnancy where a cerclage is helpful is if the cervix is less than 15 millimeters and reducing, or the membranes are exposed, that is, we're entering into the category of a rescue cerclage. Now, rescue cerclage has been shown to be beneficial in multiple pregnancy. There's no role of doing empirical cerclage or empirical Maxelf or steroids in triplet pregnancies. We are currently running a trial doing cervical lengths in triplet pregnancies and seeing whether there's role of higher dose progesterone.
Thank you. Please, Dr. Bishri.
Can I just say one thing? There is a big difference where you are practicing. If you are practicing within an institution or within a certain trust, then you've got the guidelines and you are following the guidelines, so you're usually protected by the guidelines because you follow them. You know, there is no role for tocolysis, then we'll not give tocolysis. If you're practicing in Egypt, in a private setting, then first of all, there are no guidelines. You're only, women, they tend in Egypt actually to go around and ask around. You know, if she's gone into preterm labor, she's going to blame you for not giving progesterone. So sometimes you are under the pressure of what your colleagues are doing, whether it's right or wrong. As long as it's not harmful, you know, I wouldn't put a cerclage because cerclage can have a harmful effect. But giving progesterone, even though it's a medication and we all agree that it might have side effects, but it's a common practice in Egypt. And if you're not going to do it in a woman with twins and she goes into preterm labor, you will definitely be blamed by the next clinic she walks into it, and the guy next door will tell her, well, he should have given you progesterone. So our problem in Egypt is we're not working within an institution with a clear guidelines. Everybody is following, like Professor Ghaitani said, the NICE guidelines and this and this and that. Well, the guy next door doesn't know about the NICE guidelines. He only knows that all pregnant women with twins should be on progesterone from 23 weeks till delivery.
And should be given steroids.
And should be given steroids. And if you don't do that, then you've actually, you're careless with your patient.
And the beauty of preterm labor. So would you give progesterone from 23 weeks or would you give progesterone from 16 weeks? Would you do a cervical length here in Egypt at between 16 and 20 weeks? So just before I pass the mic, the only other time where we would give progesterone, and that is irrespective of the cervical length, would be if we are doing a fetoscopic laser. If there's twin-to-twin transfusion, we've done an amnioreduction or done any sort of intervention, then yes, we would be protecting.
I would go for progesterone for twin pregnancy with the short cervix. Yes. As prophylactic progesterone and twin pregnancy without short cervix, it is controversial. I don't think it helps.
If a lady had a previous preterm birth in a single
this is another
baby,
situation.
and now she's pregnant in
Once
twins,
you have a
would
pregnancy,
you give progesterone?
yes, if you have a
Even
history
without risk factors.
if you have a history of previous preterm labor, it puts the patient in a different category. He is the high risk of developing repeat preterm labor, and she should be given progesterone.
What
With
if the
single-
opposite? What if she had a previous preterm birth in a twin pregnancy, and now she is pregnant in a singleton baby? Would you give progesterone?
I don't think there is any study which is going to answer this question up till now. You have to follow your guts. I would give her progesterone.
I just want to, so this is not an advertisement, but there is an app called Quip, QUIPP. It is an app which was produced by Professor Andrew Shannon, who I work with. It is a free app to download on Android and iPhone, and that has got these scenarios. So whether it is 1 or 2 babies, whether she's symptomatic or asymptomatic, whether she's had previous preterm delivery, previous pre-prom, or previous terminations, and the minimum cervical length. That will give you your risk for preterm delivery within 1 week, 2 weeks, 4 weeks, and prior to 34 weeks. And as a general rule of thumb, if the in the next 2 weeks is 10%, then we would be bringing them back, and we would be also giving them steroids. So that is a good app to guide the scenarios that you're saying.
So at the end of the day, accurate diagnosis is very important, and the use of transvaginal ultrasound to check cervical length is extremely important in the current practice. And glucolysis is only needed for a short term for antenatal steroids and to allow time for intrauterine transfer. At the end of the session, I would like to thank my guests and thank all the audience for their presence today. Thank you very much.
مساء الخير على حضراتكم. انا هبتدي البرزنتيشن بتاعتي ان شاء الله على طول عشان التايم ريستريكشنز اللي موجوده. ان شاء الله انا هتكلم معاكم على حاجه اللي هي لو دوز ايثينايل استرادايول containing combined oral pills. احنا في عندنا في الاسواق بيلز كتيره جدا جدا، ولكن في الاخر كل واحده فيهم بتبقى لها سبيسيفيكيشنز معينه بتخلي البيل دي ممكن تبقى مفضله للسبب الفلاني او لا. First of all، كلنا عارفين ان الكونتراسبشن هو كورنر ستون في الريبرودكتيف هيلث ان جنرال، وطبعا من حق كل كابل انهم يختاروا امتى وقد ايه يقدروا يجيبوا اطفال وايه الوقت المناسب بالنسبه لهم. النقطه المهمه في الموضوع هي ان مش كل الوسائل، طبعا هنا الكونتراسبشن في مصر مهم جدا علشان الظروف الاقتصاديه والصحيه، ولكن للاسف مش كل الوسائل زي بعضها. الوسائل بتختلف في الكفاءه بتاعتها، بحيث ان بيبقى في عندنا كل حاجه لها ميزه ولها عيب، ومهمتنا ان احنا نغربل الموضوع ونعرف ايه الامبورتنت. ايه التشالنجز اللي بتبقى موجوده لما بنيجي ننقي كونتراسبتيف؟ احنا عايزين ايه من الكونتراسبتيف؟ اول حاجه ما يكونلوش سايد افكتس كتير، قليله. ويا سلام لو انت حطيت لي حزمه من البنفيتس كمان فوق انه مجرد كونتراسبتيف. محتاج الكفاءه بتاعته تبقى عاليه، لان انا الست مش هتستخدمه النهارده عشان تحمل بكره. وكمان محتاجه انها لما تاخده تقدر تتولريت ات افكتفلي، اند اباف اول كمان يهمنا ان التكلفه بتاعته ما تبقاش تكلفه عاليه. يمكن هنا لما كانوا بيشوفوا الفيزيشنز ايه الاهميات او اولويات الاهميه في الاستخدام بالنسبه للوسائل، كان دايما بيدوروا اول حاجه على الافيكاسي، ثم السيفتي، ثم الست بتختار ايه. لان احنا عندنا الكونتراسبشن از كافيتيريا ابروتش، الست هي اللي تختار. انت مهمتك انك انت تشوف لها ايه اللي يناسبها وايه اللي ما يناسبهاش، وتقول لها عندك كذا وكذا، قالت لك اختار لي، مفيش مشكله ممكن تختار لها. يمكن موضوع الافيكاسي تضاءل تماما، لان الافيكاسي از جارانتيد دلوقتي، مفيش فيها مشكله اطلاقا. ولكن بقيت بتدور في لما تستخدم الاورال بيلز على انا مش عايزاها تزود وزني، انا عايزاها يكون لها بينيفيشال افكتس على السكين وعلى الهير وعلى الكلام ده. ده بالنسبه لها بقى اهم، لان الريلايبيليتي از جارانتيد. يمكن هنا دي ما بتعرضش، انا عندي سلايدز ثانيه بس طبعا عشان البرزنتيشن قصيره. دي بعض الحاجات اللي بتبقى موجوده ان الاورال بيلز كحزمه بنفيتس اضافيه بتديها لي، انها بتقلل الريسك بتاع الفايبرويد 17%، 50% ريدكشن في الاوفيريان كانسر القاتل الصامت سايلنت كيلر، 50% ريدكشن في البلفيك انفلاماتوري ديزيز اند ذا بريست ديزيز. للاسف 50% من الستات اللي بتاخد الاقراص بتاعت منع الحمل بتقطع بعد اقل من سنه او في نهايه سنه، و38% بيغيروا من نوع الى نوع. ولما جم يدوروا يشوفوا الاسباب ايه، لقوا من اهم الاسباب هي السايد افكتس بنسبه 37%، او نو فيرذر نيد لانها عايزه تحمل او مش محتاجه او ب 23%. ايه الترند في اقراص منع الحمل للتطوير؟ تقليل الدوز بتاعت الاستروجين قدر الامكان، دي اول حاجه. فابتدينا كان زمان 150 مايكروجرام مسترانول، بعد كده كنا احنا في الايرا بتاعه البريموفلار والانوفلار اللي كان فيهم 50، بعد كده استقرينا على ال20 او ال30 هم اللي موجودين كايثينايل استرادايول. طب وات اباوت البروجستين؟ بقينا بندور على بروجستين يكون ملوش سايد افكتس من ناحيه ايه؟ الاستروجين بيعمل لي بنفيشال افكت على الليبيد بروفايل، وللاسف الاندروجينيسيتي بتاعت البروجستينز القديمه كانت بتضيع هذا البنفيت. فطلعوا بجنريشنز احدث منها الثيرد جنريشن والفورث جنريشن اللي هي بتقول اذا ما كانوش هيعملوا حاجه فعلى الاقل ما يضيعوش البنفيتس بتاعت الاستروجين على الليبيد بروفايل. ومن هنا بقى في سيلكتيف بروجستينز. يا ترى تقليل الدوز بتاع الايثينايل استرادايول عمل ايه؟ زود التوليرابيلتي. كل ما قللت الدوز كانت التوليرابيلتي عندك بالنسبه للبرودكت بتزيد. السؤال، طب انا لما قللت وبقيت 20 بدل 30 او ده الكفاءه كانت واحده ولا لا؟ كوكرين ريفيوز قالت ايوه الكفاءه كانت واحده، بس انا قللت بعض الفاسكولار ريسكس هنشوف دلوقتي ايه، وفي نفس الوقت قللت الهرمون ويذرول سيمبتومز. يمكن الاقراص بتاعت منع الحمل ان جنرال كلها ما عدا نوع واحد اللي هو الدروسبرينون، البروجستينز اللي موجوده فيها مشتقه من اندروجينيك بوتنشاليتي 19 نور تستوستيرون جروب. اللي تحت هو اول ستيج الليفونورجستريل سكند جنريشن، طلع منه ولاده الثلاثه اللي هم النورجستيميت والجستودين والديزوجستريل. هتكلم على الديزوجستريل. الديزوجستريل is a highly selective protein. الدوز اللي انت محتاجها فور اوفيوليشن انهبيشن مش عاليه قوي زي النورجستيميت ولا النور ايثيندرون، هي متوسطه 60، والبايو افيلابيلتي تقريبا بتعادل التلتين. واذا بصينا للهاف لايف بتاعته هتلاقيها على كفاءه عاليه لا يتفوق عليها الا الاندروجينيك ليفونورجستريل. وكلمه اندروجينيك انا قصدها لان النهارده الليفونورجستريل بيلز لها ميزه لكن لها عيوب الاندروجينيسيتي بقى. من هنا جه قال لك طب ما انا هاخد الديزوجستريل ده واحطه مع بدل 30 مايكروجرام ايثينايل استرادايول احطه مع 20 بس. من هنا طلعت التابلتس بتاعت الميرسيلون اللي موجوده من سنه 88 في 50 كونتري، طبعا اكستنسيفلي ستاديد، باعوا منها اكثر من 300 مليون ستريب واكثر من 30 مليون ست بتستخدمها. السؤال، الكفاءه عاليه ولا لا؟ في 25,000 سايكل البيرل اندكس كان 0.2 بير 100 وومن يير، يعني 2 في ال1000 من الستات هم اللي حملوا عليها. في ايه؟ ده اسمه البيرفكت يوز، مش التيبيكال يوز لما تطرحها في الاسواق لان بتحصل غلطات طبعا. انما هنا في الستاديز طلعت 0.2 يعني 2 في ال1000. هنا دي بتقول ان بعض السايد افكتس اللي معروفه عن البيلز لما تيجي تبص عند زيرو ساعه ما ابتديت وتبص عند سايكل 6 هتلاقي ان كل المانيفستيشنز الثلاثه دول على قلتهم، يعني يمكن اعلى حاجه فيهم الهيدك اللي هو كان بيبقى اراوند 10% او 9%، كلهم بعد كده بيقلوا في فيز 4 ستاديز كانوا الى انهم بينزلوا الى 1 to 2% اونلي. يا ترى الوزن بيزيد ولا لا مع الاقراص؟ ممكن ده يسري على حقن منع الحمل، لكن وين ات كامز للاقراص لما كانوا بيقارنوها بانك مش مدي هرمون خالص، اولا عشان تقول لي ان الوزن زاد لازم يزيد اكتر من 7% من الويت عشان اقول ده significant weight increase. هل كان هناك هذه الزياده؟ اطلاقا، لان زي ما انتم شايفين هنا الهرمونال والاورال كونتراسبتيفز ما كانتش الزياده اكتر من كيلو واحد او كيلو ونص على مدار 40 شهر استخدام. اذا هنا انا عايز احقق المعادله الصعبه، دوز من الايستروجين قليله وفي نفس الوقت يبقى السايكل كنترول مظبوط عندي فيما يخص السبوتنج والايه والامينوريا اند. لما جينا نبص للسبوتنج او اللايت بليدنج في الحالات اللي زي دي مع سايكل 2 كان مع الميرسيلون 12.5% compared to 11% only on cycle 6 وكانت معظمها حاجات related للسبوتنج. زي ما قلت لكم الايستروجين اللي موجود دايما بيزود السكس هرمون بايندنج جلوبولين. طب ما هو البروجستين كان بيفسد، لا ده هنا ما فسدش، وبالتالي النت ريزلت لما انت بتدي الاقراص السكس هرمون بايندنج جلوبولين عندك بيزيد بنسبه 42% تقريبا، وبيتبعه ان الفري تستوستيرون اللي انت ما انتش عايزه ينطلق مين اللي هيكتفه؟ سكس هرمون بايندنج جلوبولين. قل الفري تستوستيرون باي about 80 او 75%. What about الكربوهيدرات ميتابوليزم؟ minimal if any. طب what about الليبيد بروفايل؟ انا عايز منه ايه؟ عاوز الاتش دي ال بتاعي يزيد وعاوز ال دي ال بتاعي يقل. يا ترى هل هذا الكلام كان بيحصل مع الاستخدام بالنسبه للميرسيلون؟ يس. مع الاستخدام بالنسبه له كان الاتش دي ال زاد اما ال دي ال ففعلا نقص. السؤال المهم يا ترى هيحصل ريسك اوف فينس ثرومبو امبوليزم مع الاقراص ولا لا؟ تعالوا نشوف الانسيدنس اصلا قد ايه. من 2 ل 3.7 كل 10,000 مستخدمه. طب ومع البيلز هيبقى من 7 إلى 10. الدبل اهو، دبل ايه؟ ما انت بتتكلم في الابسوليوت، بدل 4 في ال 10,000 بقوا 7 في ال 10,000. طب بقى كمل. وات اباوت ان الست تبقى بريجننت؟ being pregnant 29 في ال 10,000. وفي اول 15 يوم بعد الولاده 300 الى 400 في ال 10,000 ممكن يجي له. عايز تفهمني اللي خدت مطب الحمل ومطب البوست بارتم بيريود وعدت من غير دي في تي، هنا الثلاثه لما توصل الى 6 او 7 هتعمل مشكله؟ لا. وعموما اذا كنت هدور على النقطه دي فبرضه عايز اقول حاجه، انك لما بتستخدم الاقراص اللي فيها 20 وفيها الديزوجستريل الانسيدنس فيها كان 6.8 في ال 10,000 ودي اقل نسبه ممكنه. اللي ايد هذا الكلام دينش كوهورت ستادي قالت انك لما تستخدم اقراص فيها 20 مايكرو جرام بدل ما يكون فيها 30 ده هيقلل لك الريسك اوف دي في تي باي 23%. ولكن خلينا نبقى فير برضه عشان واحنا بنتكلم. قلت 23% يعني بدل ما كان عندي هيبقى 8 بقوا 6 او بقوا 5، يعني مش فرق كبير قوي للدرجه دي، لان زي ما قلت لكم يكفي جدا الريسك عندك اهو بتاع البريجننسي which is much more وفي الاميديت بوست بارتم بيريود. هل له نون كونتراسبتيف بنفيتس؟ تخيل هنا ان بعد 3 شهور من الاستخدام للاقراص بقت في عندك مور ذان 50% ستات عندهم الديسمينوريا بتاعتهم مش موجوده، وانتوا عارفين الانهبيشن اوف اوفيوليشن بيطير لي الديسمينوريا. وفي نفس الوقت الاحساس باستخدام الانالجيزكس عشان الديسمينوريا زي ما انتم شايفين اللون الاسود اللي هناك قل تماما بالوصول الى الثيرد سايكل. يا ترى البريمنسترول سيندروم هل في علاجها داخل ان انا ادي اقراص منع حمل؟ يس. طب لما استخدمنا الاقراص دي كانت النتيجه ايه؟ ان افتر 3 سايكلز من البيز لاين حصل عندي ديكريز من البيز لاين بنسبه 40% في البريمنسترول سيندروم. ده اللي قالته 52 سنتر كانوا بيشتغلوا على هذا الريسبكت. يمكن هنا لو اتكلمنا على السكين ليجنز اللي قلت لكم الست بتدور عليها اكني او سيبوريا او غيره، هنا في نقطة مهمة، قال لك لما تكون عندها 1 to 5 ليجنز مش هتشوف انت الايه فرق كبير قوي لما تستخدم الاقراص، لكن لما الليجنز عندك تزيد عن 10 الامبروفمنت هيبقى مرعب. all in all نسبة النجاح في الاخر الامبروفمنت لو جمعت القليل على الكتير ان هتتحسن النسبة بنسبة قد ايه السيبوريا والاكني والحاجات دي 60%. وده بيقول ان مفيش اندروجينيك بوتنشاليتي مضايقاني، لان في الاخر البروجستين ده ثيرد جنريشن ابن حلال ما بيبوظش البينيفيشال افكتس، يعني هنا ما بيطرحش اندروجينيسيتي تعمل لي مشكله معينه سواء على الليبيد بروفايل او غيره. وات اباوت اهو الاكني والسيبوريا زي ما حضراتكم شايفين البرسنت بدل الستات ما كانت 12 على ثالث سايكل بقت 5%، وبدل السيبوريا ما كانت اراوند 10% بقت نزلت الى 5%. كل الكلام ده كبنفيتس اضافيه احنا طرحناها في اول المحاضره وقلنا ان احنا عاوزينها. كل ده بيقول ايه في الاخر؟ قال لك لما طب وات اباوت الستات؟ ار they satisfied by the end of time بعد 6 cycles؟ درجه الساتسفاكشن بعد 3 cycles كانت مقاربه ل 80% and after 6 cycles it was 86%. They were satisfied completely with the product. So in conclusion, اللو دوز بيلز اللي هي ميرسيلون provides excellent contraceptive reliability زي بقيه الاقراص كلها. good cycle control، مش مضايقني قوي حكايه انها تبقى 20 مايكروجرام. shorter and lighter withdrawal bleeding. lower incidence of dysmenorrhea and premenstrual syndrome اللي احنا قلنا عليهم في السلايدز الاخيره. side effects قليله جدا if any لانك انت مقلل دوزز. neutral effect on body weight، no increase more than 1.2 to 1.4 kilogram after 40 months of use. And finally ده كله بيؤدي الى ايه في النهايه؟ increased women's satisfaction، وده طبعا هيحسن لها الكواليتي of life. Thank you very much.
احنا بس بننوه ان بعد السيشن دي لو في ورك شوب في هول سي، لو حد عايز يشوف موضوع التركيب والخلع بتاع الامبلانون اللي هو الامبلانون نيكست، فلو حد انترستد بعد السيشن في هول سي. الحقيقه انا ابتديت بس السيشن بشويه interesting numbers. يعني simply كده one baby is delivered per 15 seconds in Egypt. 5685 is delivered per day. و more than 2 million babies are delivered per year. عشان كده تخصص امراض نساء ولاده في مصر من التخصصات المحبوبه اللي الدكاتره بيحبوا يشتغلوها عشان هيشتغل ضامن ان هو يشتغل. بمعنى لو بحسبه بسيطه كده في حوالي 6000 ل 7000 اخصائي امراض نساء في مصر. لو قسمنا كده هنلاقي ان كل دكتور نساء هيولد له بتاع حوالي 300 320 طفل بير يير. مقارنه بالسويد مثلا كل دكتور نساء هيولد له بير يير حوالي 20 طفل. ال unintended deliveries او بيبيز في مصر زادوا الحقيقه، بقوا 20.5% were unintended babies مش مرغوب فيهم دلوقتي. مقارنه في 2014 كان 15.7 بيبي كان unintended، فالنسبه بتعلى. منهم 12% كانوا unintended at any point of time، يعني الاهل ما كانوش عايزين اطفال في الفتره دي خالص لغايه ما ما يموتوا. الفاميلي بلاننج سيتويشن من ايجيبت لو بصينا كده على البوبولاريتي بتاع الاستخدام، البيلز كان 16% من العيانين بيستعملوها في 2014 بقت 20% في 2021. الامبلانتس which is something surprisingly كانت 0.5% في 2014 still is low بقت 2.6 في 2021. الاي يو ديز مفيش significant difference حوالي 30% بيستعملوا. وطبعا حاجه فيري يعني بومينج ان 33% من الستات they don't use any method of contraception along their lifetime. طبعا كلنا عارفين الامبلانتس او البروتوتايب كان اللي هو النور بلانت اللي هم كانوا 6 بيتحطوا زي المروحه كده في الدراع. طبعا دول كان مشكلتهم مينلي في الريموفل، كانوا بيتكسروا، كانوا بتجيب العيانه على كذا سيشن تشيل الامبلانتس دي. مشكلتهم الثانيه ان هم ما كانوش راديو اوبيك، كانوا بيبانوا بس في في الالترا ساوند. بعد كده البوبوليشن اللي بعد كده جت اللي هي التو امبلانتس اسمها جاديل، وبعدين النكس بلانون هو الامبلانون ان اكس تي او نكست. في حاجات تانية بس مش بوبولار قوي زي اليوني بلانت ده 1 رود containing 55 ملغ of نوموجسترول، والليفو بلانت ده 2 رودز containing 75% ليفو نورجستريل. الامبلانتس القديمه كان فيها ليفو نورجستريل، الامبلانتس الجديده بقى فيها انذر بروجسترون اللي هو الايتونوجستريل. طبعا كلنا عارفين ميكانيزم اوف اكشن اوف هاي دوز بروجسترون. It inhibits ovulation, mainly inhibits LH release, بتثيكن السيرفايكال ميوكس وبتعمل اتروفيك تشينجز في الاندوميتريوم. Surprisingly, الامبلانت has got the highest efficacy in contraception. لو ما نبص كده السبدرمال implants less than 0.1% failure, which is a very very high percentage even in comparison to tubal ligation. يعني لو بصينا كده للستيرلايزيشن اقل من 0.5%، السبدرمال اقل. الهرمونال كونتيننج ايوديز 0.2%. لما نبص للحاجات اللي هي الاورال كونتراسبشن 9%، هرمونال باتش 9% فيلير، رينج 9%، الانجكتبل 6%. فايت از فيري فيري هاي very very high efficiency. ده الجن اللي هو بيريليس الامبلانون. الفارماكوكاينetics الظرف فيها كمان انها اتس رابيدلي اكتنج. وانس ان هو بيخش جسم الست، الاوفيوليشن انهبيشن concentration is reached within 1 day. في اول فتره طبعا الريليز بيبقى عالي شويه، بيبقى من 60 ل 70 مايكرو جرام بير داي in the first 5 to 6 weeks، وبعدين بيقل تدريجيا along the first year ل 35 to 45% مايكرو جرام بير داي، وبعدين في السكند يير بيبقى 30 to 40، في الثيرد يير بتبقى 25 to 30. طبعا هو بيقعد 3 years الامبلانون. في الكلينيكال ترايلز لما بنشيل بقى الامبلانون لقوا ان الاوفيوليشن بيرجع في خلال 7 ل 14 يوم افتر ريموفال. فات از فيري فيري هايلي ريفرسبل ان كومباريزن مثلا للانجكتبلز. وطبعا كانت مشكله الامبلانون الاولاني ان هو ما كانش راديو اوبيك، انما ده حطوا فيه باريوم سلفيت فبقى راديو اوبيك. ات كان بي سين باي اكس راي، ممكن الالترا ساوند طبعا السي تي والام ار اي ممكن يشوفهم، انما الجنريشنز القديمه ما كانتش بتتشاف غير بالام ار اي او بالالترا ساوند. ده نفس القصه اللي هو الديكلاين بتاع البروجستيرون ان بلاد. الانسرشن اوريكم فيديو كده بسرعه على الانسرشن بروسيدر. ممكن نعلي الصوت
The
شويه.
implant should be inserted just under the skin at the inner side of the non-dominant upper
أهم
arm,
حاجة to
about 8
avoid
to 10
البيسيكال
centimeters
groove.
above the medial epicondyle of the humerus, avoiding the sulcus or groove between the biceps and triceps muscles, and the large blood vessel. Stretch the skin around the insertion site with your thumb and index finger. Puncture the skin with the tip of the needle slightly angled less than 30 degrees. During the entire insertion procedure, you should be able to see the insertion site and the movement of the needle. Lower the applicator to a horizontal position. While lifting the skin, also known as tenting, gently insert the needle. Make sure the needle is inserted to its full length. If the needle is not inserted to its full length, the implant may protrude from the insertion site. Keep the applicator in the same position and unlock the purple slider by pushing it slightly down. Move the slider back until it stops. This will cause the needle to be fully retracted. Tissue. The implant should be inserted subdermally just under the skin. Marks with the marker. One mark at the insertion site and the second mark a few centimeters above the insertion site. The second mark will be used as a direction guide during the... Clean the insertion site with an antiseptic solution. Anesthetize the insertion area. For example, with an anesthetic spray or by injecting 2 milliliters of 1% lidocaine just under the skin along the planned insertion tunnel. Hold the applicator just above the needle at the textured surface area. Remove the transparent protection cap by sliding it horizontally in the direction of the arrow away from the needle. If the cap does not come off easily, the applicator should not be used. You can see the white implant by looking into the tip of the needle. Do not touch the purple slider until you have fully inserted the needle subdermally, as it will retract the needle and prematurely release the implant from the applicator. With your free hand, stretch the skin around the insertion site with your thumb and index finger. Puncture the skin with the tip of the needle slightly angled less than 30 degrees. It's important that you're in a position during the entire insertion procedure to clearly see the movement of the needle just under the skin. Generally, you can see movement of the needle best if you're seated and looking at the applicator from the side and not from above. Lower the applicator to a horizontal position. While lifting the skin with the tip of the needle, slide the needle to its full length. You may feel slight resistance, but do not use excessive force. If the needle is not inserted to its full length, the implant will not be inserted properly. Keep the applicator in the same position with the needle inserted to its full length. If needed, you may use your free hand to keep the applicator in the same position during this part of the procedure. Unlock the purple slider by pushing it slightly down. Move the purple slider back until it stops. The implant is now in its final subdermal position, and the needle is locked inside the body of the applicator. The applicator can now be removed. If the applicator is not
ده الانسرشن بتاعه الريموفال بسرعه كده برضو.
Location of the implant in the arm should be verified by palpation. Mark the distal end of the implant, the end closest to the elbow. A sterile marker can be used. Clean the site where the incision will be made and apply an antiseptic. Anesthetize the arm, for example with 0.5 to 1 milliliter 1% lidocaine at the marked site where the incision will be made. Be sure to inject the local anesthetic under the implant to keep it close to the skin surface. Push down the proximal end of the implant, which is the end closest to the woman's shoulder, to stabilize the implant. A bulge may appear indicating the distal end of the implant, the end closest to the elbow. Starting at the distal tip of the implant, make a longitudinal incision of 2 millimeters toward the elbow. Gently push the implant toward the incision until the implant tip is visible. If the tip of the implant is not visible, there may be fibrotic tissue encapsulating the implant. The fibrotic tissue can be split by continuing to cut toward the distal tip until the implant tip is clearly visible. Grasp the implant with forceps and gently remove it. Be sure to remove the entire implant. Confirm that the entire 4 centimeter implant has
طيب يبقى اول حاجه قلنا انها very efficient. السيفتي and tolerability طبعا هو ما فيهوش استروجين فبالتالي can be used for a wide vast majority of patients in which estrogen is contraindicated. It can be used for patients with previous ectopic لان هو بينهبت الاوفيوليشن عكس البوبس progesterone only pills. It can be used for breastfeeding patients. It can be used for patients with varicose veins اللي عندهم انيميا اللي عندهم hypertension بعض الكاردياك diseases it can be used فيها. It can be used for all parities حتى النالي gravidas. النالي gravidas it can be used for them at any age early يعني من اول 18 لغايه above 40 it can be used for them. لو قلنا الكاتيجوري 1 والكاتيجوري 2 وال 3 و 4 في الامبلانتس. Category 1 adolescents, post-abortion, postpartum, non-breastfeeding women, heavy smokers, women, الناس اللي عندهم زي احنا قلنا high blood pressure, valvular heart disease, endometriosis, endometrial or ovarian cancer. Category 2 blood pressure more than 160 over 100, history of blood clots أو diabetes with vascular complications, prolonged vaginal bleeding, multiple risks for cardiovascular problems. كاتيجوري 4 الحاجة الوحيدة اللي ما تستخدمش فيها لو هي عندها current breast cancer now. ده ال only كاتيجوري 4. كاتيجوري 3 لو عندها acute DVT, unexplained vaginal bleeding, history of breast cancer عندها, severe liver disease, infections or tumors and certain types of systemic lupus. breastfeeding لو هي قبل 6 أسابيع مش مستحب لأن هو ممكن يقلل شوية البريست ميلك إنما بعد 6 أسابيع she can use it. The benefits, it's very effective, long acting, do not interfere with intercourse, do not affect breastfeeding, contains no estrogen, no supplies required by the client, no frequently repeated visits to the clinic, no increased risk of cardiovascular complications, no delays for return of fertility, decrease ectopic pregnancy, may decrease menstrual pain and menstrual bleeding, may help to prevent iron deficiency anemia. الليميتيشنز دايما المشكله الاساسيه العانه تقول لك موضوع البليدنج وموضوع الويت جين. مع النوع الجديد اللي هو ايتونورجسترال الويت جين از فيري ليميتد، ممكن في الثلاث سنين دول ما تزيدش اكتر من 3 كيلو جرامز. البليدنج 20% بيجي لهم امينوريا، وال 3/5 بيجي لهم acceptable bleeding يعني ممكن يجي لها irregular bleeds بس ماشيه شويه مع البيريودز، يعني اتممك شويه البيريودز. والفيفث او 20% هم دول اللي بيبقى عندهم prolonged bleeds او markedly irregular bleeding. لو هي في اول 3 شهور البليدنج از acceptable غالبا هتكمل كويس. لو هي عندها unfavorable pattern في اول 3 شهور 50% will improve and 50% will stay as they are. قلنا ان فيها 68 ايتونورجسترال وقلنا موضوع البليدنج باترنز. لازم نعمل انفورميشن وكونسلنج للبيشنت وتديوز بليدنج دايري. الديسمينوريا بتتحسن في نسبه كبيره، 77% من الحالات بتتحسن. لازم نعمل كونسلنج كويس للعيانين. المشكله ان مش الموست افكتيف كونتراسبشن is the most commonly used. كونسلنج هيزود النسبه بتاعه الاستخدام بتاع الامبلانول، لان هو اكشولي 3 حاجات: it's safe, it's very efficient, and it's long acting and immediately reversible. سؤال اخراني للقاعه كده: هل الامبلانول بيعمل اوستيوبوروزز ولا لا؟ انا خلصت خلاص. هل بيعمل اوستيوبوروزز ولا لا؟ الانجكتبلز احنا عارفين انها بتعمل اوستيوبوروزز. دكتور اشرف، امبلانول بيعمل اوستيوبوروزز؟ بالظبط. very minimal degree of osteoporosis. الليفونورجسترال اللي هو كان الاولد جنريشن كان بيعمل اكتر من الايتينونورجسترال، فهو it's very very minimal. ف we need to reassure the patient that it's very good في الحالات اللي ايه ان هو ما بيسببش الاوستيوبوروز زي ما الست يعني فاكره. Thank you.